Hi, good day everyone. My name is Roberto Ernio Silinga Jr.
And I am Daniela Joy Lobo.
And in this topic, we'll be talking about chemotherapy of parasitic diseases. Hope you enjoy this video.
For the introduction, we have here different classifications of parasitic worms. We have here nematodes, cestodes, and trematodes. Nematodes are thread-like roundworms that live in a wide range of environments, including soil and fresh and salt water. There are species of nematodes that feed on fungi, bacteria, protozoans, other nematodes, and plants. We have here types of feline intestinal worms and its leg. Roundworms, which is about 3 to 6 inches, whipworm, 2 to 3 inches, hookworm 1/8 inch, and tapeworm 8 inches. Next is cestodes, or what you call tapeworm. Cestode infection spreads when eggs laid by adult tapeworms in the intestines of definitive host are excreted with feces into the environment and ingested by intermediate host, typically another species. In short, the infestation of this type of parasitic worms is when the host is eaten raw or undercooked by the definitive host. Lastly, the trematodes, or what you call flukes. Flukes are parasitic flatworms that inject the blood vessels, gastrointestinal tract, lungs, or liver. Infestations are very common in tropical areas. Travelers can contract a helminthic infection and bring it home, where the worms can infect other individuals. Most common infectious helminths are nematodes, or the roundworms, and platyhelminthes, or the flatworms, which invade the intestines and the tissues. Ascariasis, or the giant roundworm infestation, is a species of a parasitic roundworm that infects the human small intestine. It is also known as the large intestinal roundworm. Serious complications can result if worms migrate into the pancreatic duct, bile duct, gallbladder, or liver. Next is pinworm infestation. Adult pinworms inhabit the ileum and large intestine. Their lifespan is approximately 2 months. Although usually asymptomatic, some patients experience intense perianal itching. Serious complications are rare. Next is Ancylostomyiasis and Necatoriasis, or the hookworm infestation. It's most common in rural areas where hygiene is poor and people go barefoot. Adult hookworms attach to the wall of the small intestine and suck blood. Lastly, trichoriasis, or the whipworm infestation, is a larva, and adult worms inhabit the large intestine. Mature worms may live for 10 years or more. It is usually devoid of symptoms. However, when the worm burden is very large, rectal prolapse may occur.
Good day everyone. So I'll be reporting about the drug of choices for helminthiasis or parasitic infections. We have albendazole, known as Albenza for the brand name, ivermectin or stromectol, mebendazole or Vermox, praziquantel or biltricide, and pyrantel or antimint. For the mechanism of action of albendazole, albendazole inhibits the polymerization of tubulin and thereby prevents the formation of cytoplasmic microtubules. As a result, microtubule-dependent uptake of glucose is prevented. Ivermectin is an active against the tissue microfilare of all volvulus, which is the cause of orchocerciasis, but not against the adult form. Ivermectin can also be used to kill mites and lice, although these parasites are not approved targets. In addition to its use in humans, ivermectin is used widely in veterinary medicine. For the mechanism of action, ivermectin disrupts the nerve traffic and muscle function in target parasites, and by opening the chloride channels on the cell surface, which allows chloride ions to rush into the nerve and muscle cells. The resultant hyperpolarization of these cells causes paralysis followed by death. Host cells are not affected because ivermectin is selective for chloride channel in parasites. For mebendazole, Mebendazole is a drug of choice for most intestinal roundworms. Because of its relatively broad spectrum of action, mebendazole is especially useful for treatment of mixed infestation. For the mechanism of action, mebendazole prevents the uptake of glucose by susceptible intestinal worms. Glucose deprivation results in immobilization followed by slow death. Praziquantel. Praziquantel is readily absorbed by helminths. At low therapeutic concentrations, the drug produces spastic paralysis, causing detachments of worms from body tissues. At high therapeutic concentrations, praziquantel disrupts the integument of the worms, rendering the parasites vulnerable to the lethal attacks by host defenses. The pyrantel is an over-the-counter drug, which is an active against the intestinal nematodes. This drug is an alternative to mebendazole or albendazole for infestations with hookworms or pinworms. Pyrantel is depolarizing neuromuscular blocking agent that causes spastic paralysis of intestinal parasites. The paralyzed worms are cleared in the feces. So for this topic, I will be discussing the antiprotozoal drugs, specifically anti-malarial agents. So we will only limit the discussion for the two types of malaria. So we have the Plasmodium vivax and the Plasmodium falciparum. So malaria is caused by either species, which is characterized by high fever, chills, profuse sweating. However, despite similarity of symptoms, these forms of malaria are very different, especially with regard to severity of symptoms, relapse, and drug resistance. And for the life cycle of the malaria parasites, as you can see here, we have the Anopheles mosquito or the infected mosquito, which will bite the susceptible host or a human, and it will inject the parasites or the malaria parasites, which are the sporozoites, into the bloodstream. And once it will travel the bloodstream, it will go to the liver and infect the liver cells. So once inside the liver cells, the parasites will tend to multiply, and after multiplying, it will rupture, and the merozytes will infect the blood. So this is during the erythrocystic stage, and we will also, during this stage, this will show the signs and symptoms of an infection. And once the another mosquito bites the infected host, it will then transmit it to another host. So these are the tables if we were in comparison of between the Vivamax malaria and the falciparum malaria. So for the vivax malaria, which the causative organism is the Plasmodium vivax, the frequency of infection is more common and latency of symptoms is about 26 days. Intensity of symptoms is mild and the timing of febrile paroxysms is every 2 days. And probability of relapse is high and drug resistance is uncommon. For the falciparum malaria, the causative agent is the Plasmodium falciparum, which is less common, and latency of symptoms is 12 days. The intensity of symptoms is severe and timing of febrile paroxysms is irregular. Probability of relapse none, and the drug resistance is very common. So Vivamax malaria, which is the most common form, the infection begins with the inoculation of the vivax sporozoites into the host. After 26 days, merozoites emerge from the hepatocytes and attack the erythrocytes. Symptoms of malaria such as chills, fever, and sweating occur as infected erythrocytes rupture, releasing the pyrogens and other substance. Symptoms follow a cyclical pattern, peaking, declining, and peaking again every 48 hours in response to reinfection and red cell lysis. For the Plasmodium falciparum, which is the less common form of malaria, however, this is more severe than Plasmodium vivax malaria, with the mortality approximately 10% without treatment. Unlike the regular 48-hour cycle of symptoms, In Vivax malaria, falciparum malaria exhibits irregular interval of symptoms occurrence. The erythrocystic cycle of P. falciparum can lead to the destruction of up to 60% of circulating red blood cells, resulting in severe anemia and weakness. Hemoglobin release from the destroyed cells can cause darkening of urine, known as black water fever. Falciparum malaria can give rise to serious complications including pulmonary edema, hypoglycemia, and toxic encephalopathy, which is characterized by confusion, coma, and convulsions. And for the principles of anti-malarial therapy, the therapeutic objectives is drug responsiveness varies across the malaria parasite's life cycle. Erythrocystic forms are easily killed, whereas hepatic forms are more resistant. Sporozoites, the initial stage, do not respond to drugs. Antimalarial therapy has three main objectives: treatment of acute attack, which is the clinical cure, clear erythrocystic form, and resolve the symptoms. Prevention of relapse, or the radical cure, is to target and eliminate the dormant hypnozoites to prevent the future relapse. Prophylaxis, or suppressive therapy, is the use of drugs to suppress parasite growth and prevent clinical disease. And available drugs cannot prevent primary infection of the liver due to sporozoite insensitivity. Treatment of an acute attack. Clinical cure requires drugs effective against erythrocystic forms of the malaria parasite. Elimination of parasite from red blood cells stops the erythrocystic cycle and resolves symptoms. Clinical cure does not prevent relapse in Vivax malaria due to persistent hypnozoites in the liver. In falciparum malaria, successful treatment of an acute attack prevents further episodes until reinfection occurs. Prevention of relapse. For P. vivax malaria involves the presence of dormant parasites or hypnozoites in the liver. To prevent relapse, a specific drug capable of killing hepatic form is required. Eradication of hepatic P. vivax parasite is known as radical cure. A radical cure is often delayed until departure from malaria endemic region since reinfection through mosquito bites is highly likely. Postponing radical cure aims to ensure that effectiveness of the treatment by avoiding reinfection before the dormant parasites are eliminated.
So we have here prophylaxis. Prophylaxis is recommended for individuals planning to travel to malaria endemic areas. Antimalarial medication is used for prophylaxis to prevent infection of erythrocytes, although it cannot prevent primary liver infection. Prophylactic treatment aims to avoid symptoms while the parasite may still be present, often referred to as suppressive therapy. There is also non-drug measures that plays a significant role in preventing infection, that is, wearing clothing that covers as much skin as possible during mosquito biting hours, that is, dusk to dawn, and then also applying insect repellent containing diethyltoluamide to exposed skin. Sleeping under mosquito netting treated with an insecticide to further reduce the risk of mosquito bites. So we have here the major antimalarial drugs, which are the chloroquine, primaquine, quinine, quinidine, gluconate, mefloquine, artemisinin, derivatives, atuvacone, or proguanil. Here is the actions and use of chloroquine. Chloroquine is a widely used antimalarial drug, effective against erythrocytic forms of sensitive strains of P. vivax and P. falciparum. Drug of choice for mild to moderate acute attacks caused by sensitive strains. Also used for prophylaxis, which is a suppressive therapy, not active against exoerythrocytic forms or dormant hypnozoites. So we have here the mechanism of action. Chloroquine likely prevents the conversion of heat to non-toxic metabolites in the parasite. Selective concentration in parasitized erythrocytes explains its actions against erythrocytic forms. For its pharmacokinetics, rapid and complete absorption from the gastrointestinal tract. Deposits in tissues like lungs, spleen, liver, and kidneys, allowing for slow release and once-a-week dosing for prophylaxis. Primarily, non-renal excretion. For its adverse effects, low doses for prophylaxis and brief higher doses for treatment minimize serious adverse effects. Adverse effects during treatment include visual disturbances, pruritus, headache, and gastrointestinal symptoms. Taking the drug with meals can minimize gastrointestinal effects. Caution needed in patients with hepatic disease due to liver concentration. Next is primaquine. For its actions in use, primaquine is highly effective against hepatic forms of P. vivax. It is used to eradicate P. vivax from the liver and prevent relapse. The mechanism of action is unknown. For its pharmacokinetics, primaquine is well absorbed after oral administration. Absorbed drug is rapidly metabolized into low antimalarial activity products. Metabolites are excreted in the urine. The adverse effect is hemolysis. The most frequent and serious adverse effect of primaquine is hemolysis. Hemolysis can occur in patients with glucose 6-phosphate dehydrogenase deficiency. This kind of deficiency is an inherited trait more commonly found in people of African, Mediterranean, Middle Eastern, Southeast Asian, and subcontinental Indian heritage. Screening for this kind of deficiency is recommended before primaquine treatment in suspected patients. During primaquine therapy, periodic blood counts and urine monitoring should be conducted. Severe hemolysis warrants discontinuation of primaquine. Next is mefloquine. For its actions and uses, mefloquine kills erythrocytic forms of P. vivax and P. falciparum, but its mechanism of action is not fully understood. It is a drug of choice for malaria prophylaxis in areas with chloroquine-resistant P. falciparum or P. vivax. Mefloquine can also be used to treat acute attacks by these parasites. Although it is considered a second-choice agent due to neuropsychiatric effects, resistance to mefloquine can develop quickly, although the mechanism is unknown. For its pharmacokinetics, mefloquine is well absorbed orally and undergoes metabolism by hepatic CYP3A4. The drug has a prolonged half-life ranging from 1 to 4 weeks. For its adverse effects are dose-related. Mild reactions such as nausea, dizziness, and syncope may occur at prophylactic doses. Higher doses used for treatment may cause more intense reactions, including GI disturbances, nightmares, altered vision, and headache. Mefloquine can prolong the QT interval, posing a risk of severe cardiac dysrhythmias. It should be avoided by patients with dysrhythmias or QT prolongation. Central nervous system toxicity is a concern, and mefloquine can cause vertigo, confusion, psychosis, and convulsions. For its drug interactions, ketoconazole, a strong CYP3A4 inhibitor, can increase mefloquine levels, increasing the risk of dysrhythmias. Co-administration should be avoided. Rifampin, a strong CYP3A4 inducer, can reduce mefloquine levels, potentially leading to therapeutic failure. Increased dosage may be required. Next drug is artemisinin, obtained for Artemisia annua, which is sweet wormwood, is highly active against malarial parasites. Artemisinin derivatives such as artemether and artesunate are the most effective drugs for treating multi-drug resistant falciparum malaria. Artemether in combination with lumefantrine is approved for oral therapy of uncomplicated falciparum malaria in the United States. Artemether or lumefantrine or Coartem, its indications used for oral therapy of uncomplicated falciparum malaria. Efficacy, highly effective against falciparum malaria with a cure rate of over 95% after a short course of treatment. Less effective against P. vivax. The mechanism of action is artemether kills plasmodia by releasing free radicals that attack the cell membrane. Lumefantrine works like chloroquine, preventing the conversion of heme to non-toxic metabolites. So for its pharmacokinetics, for the artemether, rapid absorption with peak plasma levels reach about 2 hours after dosing, short half-life of 1.5 hours. For the lumefantrine, delayed absorption with peak plasma levels reach 6 to 8 hours after dosing. Highly lipophilic, so absorption is enhanced by dosing with fatty food. Prolonged half-life of 100 hours. That's all for our presentation, and thank you for watching.